Assalamu alaikum. Welcome to today's cataract surgery insight into a Morgagnian cataract with a spinning nucleus. I am Dr. Abdurrahman Muhammad Alam going to perform this surgery in this Morgagnian cataract with a liquefied cortex. This person has a vision of PL and is unable to see with her right eye. I have taken up this challenging case to restore her vision. I'm making a side port with a 1.2 mm MVR blade at the right hand side and at the left hand side. Now I'm staining the anterior capsule with Tryphene blue. Wash out the Tryphene blue with BSS. Now inject intercameral dispersive and cohesive OVD to form the AC. Now with the help of a cotton bud, stabilize the eye and make the main port with a 2.4 mm keratome. Again refill the anterior chamber with OVD. Now with the help of a bent cystodome, raise up a flap and a gush of fluid of liquefied cortex came out, spontaneously decompressing the capsular bag. Alhamdulillah, this is a good sign because now there is less chance of Argentinian flag from occurring. With the help of a coaxial eye handpiece, wash out the liquefied cortex. Care should be taken not to catch the rhexis flap because it can lead to rhexis extension. Now refill the anterior chamber with OVD and with the help of a rhexis holding forceps, guide the rhexis flap in a circular manner to create a continuous curvilinear capsular rhexis. This liquefied cortex sometimes comes out, visco-express it out for better visibility. Be careful, there are some calcified areas in this anterior capsule. So be careful while pulling and tearing the rhexis over those calcified spots. Always replenish the anterior chamber with OVD to have a flat anterior capsule while making the rhexis. This will cause less chance of the rhexis from extending to the periphery. With the rhexis holding forceps, always remember to pivot in the incision while making the rhexis. Yes, I have completed a beautiful circular curvilinear capsular rhexis of about 5 mm in size. With the coaxial eye handpiece, I am washing out and aspirating the liquefied cortex. From the irrigation pressure, you can see that the nucleus is spinning. I call it hydrorotation of the nucleus. How beautiful it is spinning. Now, before starting phacoemulsification, replenish the anterior chamber with dispersive OVD and cohesive OVD to form a soft shell technique. Now, groove a small center pit in the nucleus. Now perform vertical chop. This nucleus is highly mobile and rotates, but I was successful in propagating a crack. Now I'm rotating the nucleus and cracking the nucleus into two heminucleus. But there is a small fiber attaching the two heminucleus. See how the nucleus is spinning from the irrigation fluid. Now again bury and chop a piece. Still there is a pieces attached to the other piece. Keep on chopping this nucleus into multiple small pieces. I'm performing vertical chop in most of this chop maneuvers. Most of my chop maneuvers are in vertical chop method. Yes, I have completely chopped the two heminucleus into 6 small pieces. Now again replenish the anterior chamber with dispersive and cohesive OVD to form a soft cell technique. I also have introduced a bit of adrenaline injection to cause pupillary dilation. Now in quadrant mode, my assistant mistakenly pressed the antivitrective mode, so I came out, and again now I am back to quad mode to emulsify the chopped pieces. See how I am emulsifying the chopped pieces at the iris plane. With the help of the spatula, guide the chopped pieces into the phaco handpiece and emulsify it easily. The bag, there is no protective layer of epinucleus or cortex on the posterior capsule. So be careful while emulsifying these chopped pieces, because at any time the posterior capsule might come forward and get caught by the phaco handpiece and cause a PCT. To avoid this, I am again replenishing the OVD and pushing the posterior capsule posteriorly. Also, I am giving a dispersive and cohesive OVD to protect the endothelium and pushing the posterior capsule posteriorly. Remove the bubble before commencing with phacoemulsification, because this bubble might hamper the view during phacoemulsification of this small piece. You might not see the posterior capsule coming forward. I'm maneuvering this piece into the anterior chamber, and I'm keeping it at the angle, and I'm replenishing the AC with OVD, because I will implant a IOL in the PC bag, because I want to perform IOL scaffold to remove this last piece. Now this IOL is protecting the posterior capsule. Now I can easily emulsify this chopped piece without any fear of PCT occurring. Yes, I have emulsified all the small chopped pieces. Now the surgery is almost completed. Only remaining part is removing of the OVD. Because there is no cortex, I am not removing cortex. Now I am removing the OVD from behind the IOL. Always remember to remove OVD properly, because if you leave any OVD in the anterior chamber, this will cause postoperative IOP spike. Yes, the AC is formed beautifully. You can see my phaco CDE how I used in this surgery. Now I'm performing stromal hydration of the side port and main port. At the end of the surgery, I'll give intracameral antibiotic followed by subconjunctival dexamethasone injection, and the case is completed. Thank you, my dear friends. Hope this surgical video was helpful in developing your surgical skills.